Thank you.
Okay, so I'm going to close the window with everybody's pictures in it, and I'll just move it over. Okay, I think everything is good now. So today I'm going to be talking to you about the new medications that have just come out or are impending coming out and what you need to know. This is going to be a very high-level talk, not a very detailed talk. So keep that in mind. There's a lot of background behind all of these slides, and almost everything I'm giving you has a link to the original source material where you can get far more information. If you have any questions, feel free to contact Dr. McDowell, and she can contact me, and I can answer your questions for you. So, my disclosures. I work for a whole bunch of different companies, and I do expert consulting for legal cases and uh, uh, problematic patients. Anything that's interesting, I'm good. Learning objectives, describing the efficacy and safety data of the phase 3. That's the last step before you get marketed currently. Although the FDA has been moving drugs onto the market extremely fast the last 2 weeks, I've noticed. You have to explain the appropriate monitoring requirements, what patient education points there are, and what we know about them. The ones that are not yet approved, we know far less. The ones that are approved, we have the FDA's vetted information, which currently is still accurate, as opposed to like the ACIP vaccination stuff, which is now getting a little strange. And then we'll discuss the clinical use of these new and emerging medications and where they might fit into current clinical practice. So the key points. So if you only see one thing, this is it. The cheapest drug might not be the cheapest treatment. Many new psychotropics are now available. There are new LAIs available, and LAIs are one of the great underused therapeutic advances in the treatment of people with chronic severe mental illness. That usually applies mostly to people who are schizophrenic or bipolar. And finally, after 70 years since the development of chlorpromazine, we have a new mechanism of action to treat people with schizophrenia. And just to be even stranger, psychedelics are about to start hitting the market. Okay? And these are a whole new category of things. They are a heterogeneous group. There is no single psychedelic, but they all seem to work similarly in the mechanism of action, which I'm not going to go into. So, I have to start actually talking. Global cost effectiveness of medications is really important to understand and is usually lost on all of the people who are making decisions. The easiest thing in a healthcare setting to control are the medication costs because you get invoices for them. Everything else is a little bit loosey-goosey and it's harder to pin down. Medications, you can say how much that costs. So the least expensive medication is the one that actually works for your patient, the one that makes them better. And the most expensive medication is the one that doesn't work. That's delaying treatment that might be more effective, and you're wasting money by even giving it to them. That's a hard point to get across to people with green eye shades, none of who are on this call. Okay, these are the FDA psychiatric and neurologic treatments, chronological order in 24-25. Okay, so we've got a whole series here, and there's a bunch of them that are not drugs. They are digital therapeutics. These are applications. Some are prescription, some are not, that you can prescribe and download and give them a license to download it. Some pharmacies are helping their patients download it and get it set up. And these are basically ways of having the person do exercises and therapy and training to enhance the effect of medications and sometimes instead of medications. So I'll just mention one, Rejoin. That's been out for a couple years now, or just approved, but it's been around a couple years. This is a medication. Medication. This is a application prescription that enhances the antidepressant effects. And what it does is it actually trains you in CBT-like way, and there's uh, information on fMRI scans showing that it actually activates and improves the areas of the brain that are not working as well in people who are depressed. Okay, so there's a whole bunch of those, and I'm going to go through some of these, not all of them. If I go through all of them, we'll be here until Christmas. So these are the chronological approvals for psychiatric and neurologic disorders. There are a bunch of things for Duchenne's muscular dystrophy, for a variety of other indications as well. The ones that are for things that are very small groups of people have very few people tested, and they're launched with very little data. So be careful with those. If they work, they're going to work. Most of those require DNA testing before you can use them. Let's take a look at the ones that you're likely to actually be seeing, however. Rizvan, you can forget about immediately because the company that developed this is a Spanish company, and for reasons that are not obvious to me at all, they figured out after they got it approved that they don't have a very high expectation of sales, so they never bothered to launch it. Now, that's like just pouring a few $1,000,000 down the hole to get it approved. But I'm not a pharma company, so I have no idea. I talk to them and they don't listen. Okay, Ingrezza Sprinkle Valbenazine. This is now available for people with difficulty swallowing. There are a million reasons why people have difficulty swallowing things, from I don't like to take pills to um, gagging, bad reflexes on swallowing. So this has just come out, and the Ingrezza valbenazine is a sprinkle, and you're supposed to give it on applesauce. That was what they tested it with. I think you could probably use anything else, but compared to oral fasting, it takes about an hour longer to peak. It gives you a 31% lower Cmax or peak and 13% less absorbed. That's also called the AUC, area under the curve, the amount of drug absorbed. So there are some differences if you give the sprinkle, but they're all fairly small, large enough to be a little concerned about, but not likely to affect most patients because valbenazine has a large cushion on dosing. You can usually get away with small dosage adjustments with no clinical impact. So this should be fine. If the person has a little bit less benefit, then I would switch to a higher dose. Now, if you put the sprinkle with a high-fat meal, it's just like the oral with a high-fat meal, which is less absorption. Austedo, the other VMAT inhibitor for tardive dyskinesia and Huntington's chorea. This is an extended release version, so instead of needing to give twice a day, you can give this once a day. And there's no difference when fasting and when you're fed. The immediate release actually has increased absorption by 50%, and the XR is unchanged. So the XR is a much better pharmaceutical product. It works better because it's less intolerant of whether you ate or not. I'm sure you've actually had people who forgot and ate something before their medication. How many of you actually have patients who take their thyroid on a fasting stomach? Even a cup of coffee will lower thyroid absorption. Efrosi is paliperidone palmitate. This is another drug like, we'll come to that in a second. for schizophrenia, schizoaffective disorder. So this has actually two indications. You actually have to do studies in two different groups of people to get two indications. And the initial dose of this is 351 milligrams. That will be on the quiz. And then it's 39 to 234 per month. So this is comparing the Invega Sustenna, the first one out, the 1 month version of paliperidone palmitate, with the Ifrozi, which is a 1 month new injection. Now, this one actually has the initial doses rolled up into one. So 351 on day one. You don't have to give one dose and then a week later another dose. It's much simpler. It's actually obvious when you look at the pharmacokinetics of Invega Sustenna that it should work. I was on an advisory panel with them and said, it should work. If you look at your own data, it looks like it works. And they said, no, 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 this is better. So much for that. So 351 day one, and then you're at steady state by about day 2 or 3. No overlap of medications. The last day you give the oral is the day you give the injection. Then monthly maintenance doses, Ifrozi and Invega Sustenna are both the same, 39 up to 234 milligrams. Most of my patients from San Antonio State Hospital, which are serious chronic patients, unlike the ones you'd see in primary care, all of my patients float up to 234 milligrams to be able to last out the month. The maximum monthly dose per the product label is 234 milligrams. Nothing is stopping you except a formulary limitation or somebody paying for it to go above that if you need it. If you need to increase above it, I would always get a plasma concentration to justify it. Now let's look at missed dose recommendations, because that's a place where there's a difference. And missed doses are a very important problem in a number of areas and are sometimes confusing for LAIs. Basically, if you look 4 to 6 weeks, you just keep going. 6 weeks to up to 6 months, you resume and you give them a little dose extra, okay? And 6 months on, you're basically at baseline, start over, okay? Now, it's important to take the first dose of these in the deltoid, okay? Because the deltoid injections have about 1/3 higher blood flow through the muscle, so it picks up faster, so you get to steady state faster. These are the things that actually work. Everybody has patients that, if you have schizophrenic patients, that are not doing well enough. And the best marker for them not doing well enough is that the clinicians are anxious to give them something else to try and make them get better. It almost always does not work. However, this is gleaning all of the information from the best I can find about where it does actually have an effect. ES, I should have put the key on, oh, I did put it there. Effect size. This is usually Cohen's D or Hedges G effect size. It's how many standard deviations I've moved the peaks of the two groups apart by using this strategy. So in the case of the first item, sodium benzoate and memantine for persistent positive symptoms has a small to moderate effect size. Small to moderate means that, yeah, it's having an effect. You can sort of see it. People will agree with you, okay? You're not hitting a home run. Now, risperidone, trospium, trospitron, pioglitazone, minocycline, and memantine have moderate to large benefits in reducing negative symptoms, the ones where the patient doesn't function well. They just sit in their room and don't do anything. They don't talk to people. They don't engage on doing anything. They don't make plans well. So these are drugs that showed more augmentation benefits. When you add clozapine to antipsychotics for negative symptoms, you get small to moderate, again, effects. Now, you have to be careful about which drugs you're adding to clozapine. Some of them actually have non-overlapping mechanisms of action and seem to have more benefit. So talk to somebody who understands the pharmacology, and if you don't know who to talk to, contact one of your local pharmacists that's in psychiatry, or have somebody contact me. Clozapine added to duloxetine for reducing negative symptoms actually has a large effect size. This is one I've never tried, but that is really something that looked much better. So maybe that's a great idea. Clozapine, of course, is actually a wonderful drug, but it actually only shows significant differences from the other antipsychotics on efficacy for people who have refractory schizophrenia. If you just give it to everybody coming in the door, which was done in China for a number of years, it has the same effect as all the other antipsychotics. If you look at the people that have refractory symptoms, they do much better on clozapine. Clozapine is tremendously underutilized in the United States, along with some of the other things we'll get to in a minute. So, moving right along, and I think I'm pretty much on time. This is the timeline of things that were approved for treating schizophrenia. ECT, we're still using. Insulin coma, not so much. That was 100 milligram, 100 units of regular insulin, IV, and then after they seize, you chase it with 50 milligrams of dextrose to stop the seizures and get their glucose to come up off of zero. And if it works, you're great, but if it didn't get up fast enough, then they have brain damage. Not used anymore. Reserpine causes a tremendous amount of depression. Reserpine is another drug that hits that VMAT transporter system for dopamine, and it shuts it down, and it shuts it down so well that people get very depressed. It was approved originally for hypertension. So the first real innovation we have is chlorpromazine in 1954. And that was a dramatic difference because that was the first thing we could use that really affected patients' behavior and made a difference. The effect size of chlorpromazine compared to placebo was gigantic then in 1950s. The reason it's less now, and if you look at studies, the effect sizes go down with time, is because we don't let people stay unmedicated for as long now, and we know how to treat people that are not doing well. Beginning in the late 50s, haloperidol came out, flufenazine, thioridazine, loxapine, perfenazine, and the other first-generation antipsychotics. Those were all a problem because of severe movement disorders. Tardive dyskinesia, Parkinsonism, akathisia, all of those were problems from that first generation. Then clozapine came back on the market. It was pulled because of agranulocytosis. And at the time, now Novartis, but then Sandoz did a gigantic study, the largest study of schizophrenia ever done. I worked on that back in the day. And this showed that clozapine was much better than the other drugs. It was very impressive. And since that came out, we've had other things that tried to reproduce that effect without the agranulocytosis and the need for monitoring. There's no REMS system for clozapine now, but there is a requirement for monitoring. Risperidone, olanzapine, quetiapine, and ziprasidone came out in the 90s. in the 2000s, we had aripiprazole. This was unique because this was the first partial agonist antipsychotic. It partially blocked the dopamine receptor, but also when it was bound, acted a little bit like a dopamine agonist. So that came out in the 2000s along with paliperidone. Paliperidone, when we were studying it, was known as son of risperidone. It is 9-hydroxyrisperidone. If you look at the product label for risperidone, it has this thing called active moiety. Active moiety means the combination of risperidone and paliperidone. In the 2010s, we got acenetine, iloperidone, lurasidone, and then in the 2020s, brexpiprazole, another partial agonist, and cariprazine, another partial agonist, and lumateperone. Okay, lumateperone's a little bit different than the other drugs. Not a topic for today. Now, xanomeline trospium came out last year. Now, this is the first in a new FDA category they created for xanomeline and trospium. This is not an antipsychotic. This is a medication that is a combination by the approved product label of xanomeline, a muscarinic agonist, and trospium chloride, a muscarinic antagonist, indicated for the treatment of schizophrenia in adults. It is not a dopamine receptor blocker. So this is a completely different kind of thing. This is a new kid on the block. So this has very different effects, and we're going to go into that in a little teeny bit of depth, not a lot. Okay, now this works on cholinergic modulation. That's a presynaptic way to regulate dopamine. Schizophrenia is now known to be a predominantly presynaptic disorder. It's not the postsynaptic dopamine receptor systems that are deranged. It's the presynaptic side that is not working correctly. So the combination of these two, well, actually the xanomeline part, gives you M1 receptor activation. That is in generally the forebrain, the dorsolateral prefrontal cortex, forebrain, and that increases GABA levels, which through an interneuron system lowers glutamate, and then that reduces the presynaptic dopamine release. So lowering glutamate lowers dopamine. In addition, and this is unique so far, it also has muscarinic M4 inhibitory autoreceptor activation. That's like a triple negative. This is the autoreceptor is what regulates acetylcholine, and it inhibits the autoreceptor to produce more acetylcholine and activate it. So this lowers acetylcholine, and this is not in the forebrain. This is now in the back parts of the brain and through what's called an A9, A10 mechanism. You don't need that. Actually comes around and through a fairly convoluted pathway also lowers presynaptic dopamine release. So we have two things that are working synergistically to lower presynaptic dopamine release. This does not affect the postsynaptic dopamine receptors at all. So all the problems you get from dopamine receptor blockade, tardive dyskinesia, Parkinsonism, all of that, not there. Okay? So the muscarinic agonists are indicated for the treatment of schizophrenia. They might have other indications. We don't know what they might be. They're not yet tested. There are studies running. And up to when this was marketed in 2024, you can call this the D2 Me Too antipsychotic era. All of the drugs modulated the postsynaptic D2 receptor by blocking it to a larger or lesser extent. So after this, we now have a dawn of a new post-D2 era 70 years after chlorpromazine. That was a long wait. Now, X plus T, xanomeline trospium, is similar to olanzapine PANSS total score versus placebo. So what I did is I dredged up, and this was actually harder than I thought when I started to build this slide. Xanomeline trospium was tried in 3 randomized, double-blind, placebo-controlled 5-week trials. Why 5 weeks? 5 weeks because 1, they're cheaper, and 2, the FDA said you only have to go 5 weeks because there's a significant difference or not by 5 weeks in all the other studies, so why bother? At the time they started that study, the original company, Karuna, had 5 employees. They were running everything through contracts, but they were right on top of them and they followed it very carefully. They were very well done studies. So the PANSS total score improvement I'm showing you, then the difference 9.6 points with a confidence interval of 12.4 to 7.3. Now, how much of a difference on the PANSS total score does it take to be a clinically significant visible improvement? About 13 points. Okay, so you're right there. Okay, but the improvement, Cohen's D in this case, the effect size is 0.65. That's combining all these studies. 0.65 is pretty good. That's at the upper edge of moderate improvement. 41% have over a 30% change from baseline, and that's considered a responder for schizophrenia. How much is the number needed to treat to get to that 30% change? 4.9. So if I treat 5 people with placebo and 5 people with X plus T, I will see 1 more person that is a responder. Okay, that's as good as anything else we've got. Effect size for olanzapine, you can see this is a meta-analysis of mostly 6-week trials. This is from Stefan Leut's excellent meta-analysis, which I gave you the link for. And if you downloaded that, you can't click on your screen, but if you downloaded the PDF, you can click on that. It's an excellent article. It's a little confusing if you haven't read a meta-analysis, but it's a good education. And the effect size for olanzapine, which is considered probably our best antipsychotic in general, 0.59. So this is at least comparable to the best we've got. Now, these are muscarinic agents, not dopamine blockers. So they have much different adverse effects. So here I'm comparing X plus T to quetiapine. Quetiapine is generally considered the least adverse effect inducing antipsychotic in common use. Effect size 0.65 for xanomeline trospium, I just showed you that, and effect size for quetiapine 0.44, weaker. Okay, if you have patients that are responding, they don't need anything else, they're doing well. Now, the number needed to harm, NNH, number needed to harm to discontinue them, to discontinue for adverse effects, is 50. So if I treat 50 people with xanomeline trospium and 50 people with placebo, I'll have 1 more person who wants to drop out and not continue to take it on the xanomeline trospium than on the group of placebo. For quetiapine, that's 10. The main complaint for quetiapine, top of the list there, somnolence. By the way, you should all know that there's been somnolence and sedation. Sedation is intentional. Somnolence is an adverse effect. Who knew until actually it came up in a study? So dry mouth, dizziness, dyspepsia, those are the common drug-related adverse events of quetiapine. The common drug-related adverse events are those that are over 5% in any dose group and double placebo. Those are the ones I always counsel patients about. I counsel patients on the warnings and precautions, the common drug-related adverse events, and then I tell them if anything changes and bothers you, call me. That covers everything else. Now, on the xanomeline trospium side, we have cholinergic adverse effects. Nausea, vomiting, diarrhea. Always familiar. That's the answer to almost every pharmacology question if you were a pharmacy student. Anticholinergic. You also get nausea, vomiting, diarrhea. So you can't tell what it is just from that. But you also get some hypertension, not much, but I check them. Dyspepsia, abdominal pain, which I think is basically another version of dyspepsia, dizziness, tachycardia, and of course, constipation. You also get gastroesophageal reflux. I'm not sure where that fits into the cholinergic, anticholinergic paradigm. If anybody knows, let me know. Okay, so moving right along, X plus T's warnings and precautions are quite different. This is the list of the warnings and precautions. So urinary retention, decreased gastrointestinal motility, increased heart rate. You can read the rest. One of these that I didn't expect was actually a real issue was narrow angle glaucoma. I never saw a person at San Antonio State Hospital with narrow angle glaucoma. And we put people for a lot of my career on cogentin all the time. Never do that now, but all the time. And we never had a problem. We always sent them to the ophthalmologist. Never had narrow angle glaucoma. So I looked it up to figure out what percentage is this. It must be really low in the United States. It's 15%. Okay, so I just never saw them. Biliary disease, you have to check for before you give it, okay? And hepatic impairment as well. And central nervous system effects, which is what we're giving it for. Now, what's missing compared to the older dopamine receptor blockers? These are all the things that are not present. There's no boxed warning. By the way, they're not black box warnings. They're just printed with a black box. It's a boxed warning. That means it's an important warning. Tardive dyskinesia or any other movement disorders related to dopamine. There's no cardiac QT prolongation effects. Remember, there is some hypertension, so check that, but no QT prolongation. And there's no metabolic disorders or weight gain. Had a great slide I didn't include about showing that actually causes slight amount of weight loss over a year, but not as good as a GLP-1. Okay, so that's on that. Now, this is, for full disclosure, this is an AI-produced drawing that I made. This is the only actual AI drawing I've ever made. I said I wanted something that illustrated psychedelic medications. I got this back, which I thought was outstanding. This was using Google Gemini. That's actually really very good as an AI. Always remember, AIs will be very happy to tell you anything it thinks you want to know, true or not. So you got to verify everything you get from an AI. So it's a good place to do a search. Go check every reference, pull it, make sure it actually says what it said it said. So this is going to be the 10,000-foot overview of the psychedelics. This is everything in phase 2 or 3 and references to go dig into it more if you actually care. And you can see that we've got psilocybin, MDMA, LSD, DMT, 5-methyl DMT, ketamine, S-ketamine, ibogaine, ayahuasca, and salvia divinorum, which I actually have never heard of at all before. And these are all the things that are being tested to treat. I think you'll see psilocybin and possibly LSD approaching the market in 2026. Now, the interesting one, I think, is if you look at LSD for anxiety disorders, it's tested for GAD. This study was different than most of the other psychedelic studies. The standard paradigm people used in the psychedelic studies was you brought them in for like 3 sessions of counseling about what to expect, what they should be expecting, how to deal with it, everything else. Then there's the session where you have somebody with them for like the day. And they usually use psilocybin for many of these because it lasts less time, so you can have them go home at night. If you have them on LSD, they usually have to stay overnight. That's more expensive. And this had then, for most of the studies, 3 sessions after the dose of the psychedelic to process the psychedelic experience. Okay, so you had 3 sessions coming in over a week apart at least, the session with the drug, and then 3 weeks of post session integration sessions. The LSD study didn't do any of that. They just had the person come in, they dosed them, and they kept them overnight and sent them home in the morning. And this works very well. 1 dose lasts at least a week to peak and about 12 weeks duration. Most of the patients held on perfectly fine for 12 weeks with their anxiety under control. They're running another study now where they're looking at giving a repeat dose when asked. Okay? So these are things that actually the psychedelics are being tested for. Remember that psychedelics were given a bad name because of the bad trips people had. And most of those were due to the shutting down of the labs that were making high quality things like LSD and calibrating the dose, and basically arresting all those people who were at UC Berkeley and at graduate chemistry department. And it was replaced by all the people who had had a high school chemistry course and that was it. And they had no idea what they were doing. And they produced things that were LSD and a whole bunch of cogeners. And then they produced wildly variable doses. And the LSD dose that was popular as the correct dose to take in the 60s, Timothy Leary and all that, was 100 micrograms. The studies show 100 micrograms is the best dose now for GAD at least. Well, if you look at what happened in the 70s, they were getting doses of anywhere from 10 to 15 micrograms up to 500 micrograms. Let me assure you, 500 micrograms of LSD is a bad day. Okay? A very, very bad day. Anyway, so that's all I've got for this, and I'm looking forward to hearing your questions.
Steve, thank you so much. That was great. We've got a bunch of questions in the chat, so we'll go ahead and start with those questions, and then we will open it up to our audience members as well. So first question, actually, Stephen, you had a couple questions. Do you want to just come off of mute and ask your questions?
Yeah, let me get my camera back on. There we go. So in treatment team, I probably, based on that slide with a good size effect, I probably need to be talking to providers about augmenting with memantidine. And it's not just for the elderly, because I think that's what maybe a lot of our practitioners think of it as somebody that.
Well, memantine is a really benign drug. I mean, compared to all the other drugs that were tested for dementia and Alzheimer's specifically, that was the mildest adverse effect profile of all of them. If I have dementia, which you can judge on your own, I'm going to take memantine first of the treatments. There's also the newer drugs that are out there that are amyloid modulating that are on that list of new drugs too, that have some bad side effects, but we're learning how to treat those. So they're not as bad as you might think from reading the adverse effect rates. Okay, but they're also very expensive and require a lot of dosing. Okay, so I would look at duloxetine. That's not a benign drug. There are side effects to duloxetine, but that looks very good. I have never tried that one, so let me know how it works. And by the way, I have noticed that when you go around and talk to a bunch of clinicians in different parts of the country, every clinician has a different little population of people, and they respond differently.
Yeah, I
Yeah,
would I would want to say like maybe Corey can jump in. Dr. Weathers like could jump in, and I believe he's been an advocate and has some experience and has talked about using duloxetine. Is that correct, Corey?
Yeah, we use it quite a bit. It actually comes from an Echo Talk years ago where they presented a really good study about GAD in Cymbalta. And since that time, I think we've used it a little more. It was a 2009 Lancet study, I think, but don't quote me on that, something like that.
yeah, this is for negative symptoms of schizophrenia. Duloxetine, I've had a ton of use for other things. I probably used it in schizophrenics too for other reasons, but never noticed the effect on the negative symptoms specifically.
Yeah, so my second question, you did answer a couple of slides later with the talking about like that the X plus T not being a QTC concern. And then I always have since we have a fixed formulary and we always want to make sure that patients can discharge on meds they can afford. That's why like the first question about augmenting with affordable meds there. But then also has there been anyone or have you guys at your hospital done any of I don't want to butcher it, trospium, just the T by itself? Because that seems incredibly affordable and if you could talk on that.
No, I have not. The one I couldn't pronounce,
Yeah, yeah,
that you couldn't
I
pronounce,
couldn't pronounce. Yeah, the
I I know nothing really about that. That's not a drug that has ever appeared on my radar.
okay, okay. And then the last question I had was for our practitioners, we want to be able to give them resources. You had great resources on that last slide, but is there a gold standard of where you would like steer providers to if they're wanting to do their research on psychedelics? Because if you put in a Google search, you're going to be down a rabbit hole incredibly quickly.
Um, I would say that right now, all you're going to get are preliminary study results that are basically unvetted by a panel of scientists like the FDA normally does. They review it, they discuss it, and they finally approve what they're allowed to say to market the drug. Uh, I don't know where you could go right now. There are Canadian studies that are more advanced than the ones in the US. There are probably a large number of studies that are published that I would look at before I would look at a wide open Google search, which now is AI, by the way. And I don't know what you're going to get except a lot of noise. And you have a lot of people making a lot of claims without any good evidence. And I, for example, I know a lot of things that I don't have anything published on. I won't use that. If I can't give you a reference, it's currently hearsay. Okay. And until I can actually look at the data, uh, I don't know.
I guess I then would also, for our providers, ask if they want to learn more about the digital therapeutics that you talked about. Is there a gold standard or place that you would steer providers to as a resource that's unbiased?
No, same problem. The digital therapeutics are all different. There are several that have been tried for things they didn't get a significant effect and were not approved. There are a variety of things coming out. There's a just approved, I think, 2 weeks ago, a, a transcranial DC stimulator for cognitive enhancing effects, uh, don't go take a 9-volt battery and hook it up to your head. But uh, there's so many variables on all of these things that I don't know if there's any summary that makes any sense. If you go pull the product label on them, you can at least get a good summary of what it's like. And most of them have published studies at this point, or many of them have published studies.
And I'll sit back and let the rest of the group participate. I apologize for dominating.
Thanks, Stephen. We've got 3 or 4 more really good questions that I definitely want to get through in the chat. And then if we have time, we'll kind of open it up past then. But from Sarah Rogers, are there going to be any studies for muscarinic receptor drugs that go for longer than 5 weeks? It would be interesting to see if the brain adapts to its receptor effects.
The studies that were used that I showed you were what are called the phase 3 registration studies. That is not the last study they do on these. After people get out of that study, they are almost always, if they think the drug's working at all, are allowed to enroll in an extension study if they want. It's another consent form. Nobody's forced into it. And those usually extend a year, some go 2 years. The longer the better, because our patients are on these forever. So there's 1-year data on Cobenfy out, the xanomeline trospium product. And there are a number of other muscarinic drugs in development. Got a really nice slide that I didn't get to that gives you a whole list of them. But you can go pull up muscarinic drugs and schizophrenia or psychosis, and you can get a list really fast. Wikipedia is a really good reference because unless it's a controversial topic, it's really well vetted. If it's a controversial topic, which is stuff you might not think of, it's just noise. But like statistics, you can go to Wikipedia and get a good discussion on a statistics test. So I would go look there for like an overview, and they usually give you decent references. And what was the other part of your question?
She just said it would be interesting to see if the brain adapts to its receptor effects.
Apparently, no. There are some systems in the brain that have a rapid adaptation effect. Norepinephrine receptors reset in just a number of days, the half-life about 3 days, and it resets. So if you have hypotension from a drug, usually it'll fade away in about 3 days. If people not being able to get their head off the pillow for 3 days is not acceptable, but if they feel a teeny bit dizzy, telling them to get up slowly and see if it goes away for a few days is usually effective. I always remind people that get dizzy, sit down wherever you are. It's much less embarrassing to sit on the floor at a party than it is to not sit down, fall over, cut your head, call EMS, ends the party.
Thank you. Next question from Andy Bradbury. Second generation antipsychotics are often used in low dose as adjuncts to antidepressants. In these low doses, is there much risk for TD or for worrisome metabolic effects?
Same risks. The low doses are actually usually up to about half of what they are for like a major psychotic disorder. It varies a lot. People have different metabolic capabilities, so they might need a very different dose than other people, but I would put them on a relatively low dose that you don't think is effective, so the person can get used to it before they start having any effects, and then slowly titrate it up until they benefit. If they have an adverse effect, go to the previous dose. And I would do that every week or two. If you've got time, if you're dealing with an outpatient, you should have time. So don't rush, and you can get a lot farther with the benefits of these drugs. But a great number of people need these second generation drugs for major depressive disorder and bipolar depression. Keep in mind right now, half of all the use of these second generation antipsychotics is for people with mood disorders.
Great. Okay, we've got 4 minutes for two questions. Um, Corey said interactions that stand out to you with the Cobenfy, I think is that how you say it?
Okay, this is another major difference. The two drugs are metabolized by very different mechanisms, and they're very different than all the other drugs we normally use in psychiatry. If you're in family practice or something like that, you have other drugs that are going through these same systems. Trospium is eliminated by active tubular transport in the kidney. So you've got to worry about active transport blocking things. Xanomeline has some strange effects on CYP3A4. It blocks CYP3A4 in the gut transiently. So if you had a drug that was given parenterally, I don't know what that would be specifically, but that wouldn't have an effect at all. But if you give it with oral medication, you will see an interaction there. So be very careful about that. They're very different drugs, okay? And I would be cautious about doing anything without taking a look and making sure it looks okay.
Thank you. And last question, we do have quite a few behavioral health providers who attend our sessions. So this one is for them from Catherine. I know this is a broad question, but are there any standout symptoms or side effects that mental health professionals should be looking out for with antipsychotics that would be evident in our therapy sessions?
I think movement disorders would stand out and be obvious. If you don't know what they look like, ask one of the other clinicians who treats patients all the time that have them. Things like lack of expression in the face. It's not necessarily just depression. It could be Parkinsonian symptoms. A shuffling gait, a tremor in the hand, um, not jerky, but just a regular repetitive tremor. Things like that are Parkinsonian symptoms. Lack of balance is a Parkinsonian symptom. So there's a lot of things that if you are just a therapist, you actually have a better chance of picking this up than anybody else because you're seeing the person longer in a standardized setting where this is not a topic about medications. And the one who sees the person for medications, I don't know how long your visits are, but 10 to 20 minutes is about the range I've seen. And 10 minutes is not enough time to actually do anything, including making a note.
Steve, thank you so much. This was a fantastic session. Thank you to everyone for your wonderful questions too. Thanks for closing it out that way to kind of to help us reach our whole audience here that we have today. Just as a reminder, Steve's slides are available on our website on the overview page, so you can grab them there. And if you have any questions specifically for Dr. Saklad, just email them to me or put them in your post-session survey, and we can always send those over to him. But Steve, thank you so much for being here today. We really
You're
appreciate
welcome.
you.
And I hope your weather improves a little bit.
Thank you. Yes.
Mine is actually rainy and cold. So
Yeah.
not cold, Idaho cold, but cold for me, it's 49 degrees. But
Well, that might be actually about the same temperature as us.
yeah,
Uh,
the weather is weird.
it is.
Okay, thank you all.
Thank you. We are going to be back after the holidays on Wednesday, January 7th for the first session of 2026. We have Dr. Abhilash Desai, who's the medical director of Idaho Memory and Aging Center, and he'll be presenting on mood disorders in the geriatric population. So make sure you are signed up and ready to go for 2026. Thanks, everyone. Happy holidays. Have a great rest of your week and a wonderful holiday season.